had the opportunity to look it over. Any questions? Yeah.
So H and D curve, I mean, I read through chapter 21. I didn't see it in chapter 21. Is this the extent of what we need to know
Yep.
about H and D curve?
Yep.
Okay.
Yep. Yep. H and D curve, everything that you need to know is on here, and it can really be summed up by, speed closest to the vertical axis. Contrast is determined by the steepness of the straight line portion, vertical, high contrast, horizontal, low contrast. The portions, you got shoulder, toe, straight line portion. Yeah. So what you might see eventually in reference to both contrast and the H and D curve is what we refer to as average gradient. Average gradient just means the slope of that curve. So it's calculated, it's probably a little deeper than what we need, but calculated as rise over run, how far out it goes compared to how high it goes, rise over run, the slope of the hill, slope of the roof of the house, basically.
What does that mean? Like, what does H&D mean?
H&D, good question. It's Herder and Dryfield. So it's named after the people who, developed it. So it's H&D curve, sometimes referred to as D log E curve, sensitometric curve. All of those things mean the same thing.
So the characteristic curve and the H&D curve
Characteristic curve.
They're the same thing?
Yeah, yep, yep. They're the exact same thing. So 4 different names for one thing. This is radiology. We can't make it simple. Well, I propose we start at the bottom and work our way up, because there are some things that I didn't think to talk about very much, and some things that kind of bleed over into the next section. So, your contrast and density is really controlled by your computer algorithm now. I'm not saying that KVP and mass have no effect, but they only really have an effect in the extreme. So unless you really mess something up, your technique is going to result in a good image. So if you get anywhere in the ballpark, and it's a pretty big ballpark now, your image is going to show up on the image looking good. The only indication that you have that you over or underexposed patient in a lot of cases is just your index number, right? So the technical factors, I have this entire section down here at the bottom is about sharpness of reported detail, and KVP has no effect on sharpness. It might have a little bit of an effect on visibility because of scatter radiation, but really it's going to be negligible, not much at all. Mass, you can't have an effect on sharpness of reported detail. That's for 2 different reasons. One is blooming of the space charge. We talked about that in the last section. So if you use a very high MA station or long prep time, then what you can create is too large of a cloud of electrons. Your thermonic emissions exceed the ability of the focusing cup to keep everything compressed, right? So then you've got, in that case, a larger focal spot size than what you had intended to have, and therefore your sharpness of reported detail could suffer a little bit. So mass can affect sharpness of reported detail in that way. Also excessive time. So if your time gets too long, then you introduce the possibility of motion artifacts. So those are the ways that mass can affect your sharpness of reported detail. KVP has no effect on sharpness of reported detail. So image receptors, we've got a couple of things on image receptors that we kind of touched on a little bit, and they're kind of the same but a little bit different. With your DR image receptors, think of the image receptors as being composed of a whole lot of little bitty individual computer elements, right? With CR, what you have are individual little bitty phosphors, kind of like, I don't know if you took the opportunity to watch the videos where I made exposure of the intensifying screens. It's in one of the videos, and they're, you know, on the website separately as well. You just kind of have to dig for them. But the CR cassettes work in a lot the same way. They glow whenever you first make an exposure, but they hang on to some of the energy that you know is imparted to them by the X-ray beam. And the smaller those individual little phosphors are, the more sharpness you're going to have. All right. So if you have one great big phosphor that's, you know, the size of your head, and you're trying to make an image of the hand, and the whole phosphor glows, are you going to be able to tell that's a hand?
No.
And the answer is no. So you need little bitty phosphors for good sharpness. And in the same way, your DR images or DR image receptors have to have individual tiny little bitty detectors in order to have high sharpness or recorded detail. So your sharpness or recorded detail then is dependent, actual sharpness is dependent on the size of those things, much like a pixel, right? So what you want is tiny pixels in a large matrix. Okay, and by large matrix, I don't mean a big screen. I mean big numbers in a relatively small screen. You know, because if you have, you know, a massive screen and you don't keep small pixel size, you're still going to be pixelated, and it's still going to have low sharpness recorded detail. Okay, so small pixels or small phosphors, if it's a CR cassette, in a large matrix. Okay, so that's your sharpness recorded detail. And also, though, we can have high sharpness without being able to visualize that, and that is in large part because what we use in the Lightroom workstation computers and in the examination room are low resolution monitors, right? So even if we have perfect sharpness on the image receptor, that does not translate to perfect sharpness in display. We have to have high resolution display monitors, and that's what the radiologists have. Okay, so and again, that goes back to pixel size in the size of the matrix. Okay, so matrix, pixel size. So sharpness for recorded detail is not really controlled by the computer algorithm. Visibility is. Collimation doesn't really do anything for sharpness or recorded detail. I did add something to that, and that is what, you know, I really don't even know that this is equipment that's used anymore. Extension cones, if you remember back to the first part of last semester, all the different types of beam restrictors. We had diaphragms, we had cones, and we had collimators, right? So an extension cone could reduce sharpness of recorded detail. That's what we refer to as cone cutting. And it's just because of the construction of the cone and how the X-rays interact with that at the distal end of the cone. So you're probably never going to see anything about that, but I wanted to include it just in case you did, because then you might be confused and say, wait a minute, cone is a type of collimation. Collimation can affect sharpness for recorded detail only in that one case.
What about like better collimation making less scatter?
Yeah, absolutely. But that's a visibility function.
Visibility. Okay.
Yeah.
So that has nothing to do with sharpness.
It has nothing to do with sharpness, but we're going to hammer that. I'm going to beat on collimation from now until y'all graduate. You know,
But it's just all visibility.
it's all visibility. Yeah, and it's really because our visibility has so much more to do with computer algorithm now.
Mm-hmm.
It's really about radiation exposure.
Yeah.
More than anything else, and that's why I'm going to beat on it, is because a lot of the images I'm seeing on the internet and Facebook groups and all that, this collimation is just wide open. Nobody's collimating anymore. I don't know if it's not being taught or if it's radiologist preference, and if it is a radiologist preference, except for in very few cases, it's just wrong. You know, we need to be using collimation. It's radiation exposure. But you know, that's a little bit of a rant, but collimation is visibility and not sharpness. positioning though can have some issues with sharpness. So we talked about the L spine, right? If we shoot the L spine PA, then the beam divergence more closely follows the disc spaces, right? If we shoot the wrist bones AP, we put the fattest portion of the bones closest to the image receptor and increase sharpness for recorded detail. I always ask the question, so why do we not do wrists AP? Because of the that would be the ulnar-styloid process, possibly. And if that's the case, that's the only thing I can come up with. You know, and my answer to that is always, I don't know why we don't shoot an AP. You know, if we get a better image, better joint spaces AP as opposed to PA, it's something that maybe we ought to flip around. Probably never going to see it, but anyway. So centering, also, if you remember, we can have an issue with parallax. Remember doing this? If we're parallel to if our anatomy, you know, is in if we're parallel to the center of the central ray, and our anatomy looks like that, off in the distance in the periphery of the beam, we're going to have some distortion. Distortion is a sharpness issue. All right, so center on the anatomy of interest. What can be done to ensure the highest spatial resolution? Your go-to on that is three things. That is low OID, adequate SID, and the higher the SID, the better off you are. Small focal spot size. So those are your three things. SID, OID, focal spot size are the main three things. Everything else is kind of secondary and assuming that you position properly, right? Also with sharpness for recorded detail, remember the things that we talked about before. If you increase OID, you overcome the effects of that increase in OID with an increase in SID. And if you can't increase your SID because you're doing macro radiography, or if you're working on a system where you can't physically, it's locked into place at maybe 40 inches like C-arm, then you can use small focal spot size to overcome some of that. All right, so ways to limit voluntary motion. So we have two different types of motion: voluntary and involuntary. Ways to limit involuntary motion. The most effective way is
Be quick.
just good instructions. Yeah, tell the patient what you want them to do. Tell them what their expectations are. And then for involuntary motion, that would be short exposure time. How you get to that short exposure time could be reciprocity, increase your MA, decrease your mass to maintain the same, or increase MA, decrease your time to maintain the same mass. Or you could increase your KVP and reduce your time to take advantage of the 15% rule, and reduce motion in that way. All right, so then we'll get back up to the next big thing is heel effect. We didn't talk about the heel effect in this semester, but we've talked about it in the past. That's a difference in intensity at the image receptor between the cathode end and the anode end of the X-ray tube. It's really a difference in emission, but its effects are seen on the image receptor. So it's difference in intensity. We have an increase in intensity at the cathode end of the X-ray tube versus the anode end, and the reason for that is because of the filtration effects of the anode. You know, the book seems to imply that, you know, this genius idea of angle in the anode is, you know, gives us that line focus principle so that we can have a sharper image, you know, but really in effect, we have to use that bouncing type of effect where our X-rays travel across the tube, hit the anode, and then, you know, are reflected off of the anode. Because we just can't put we can't shoot straight through the anode and get an exposure. The anode would just absorb the whole thing. So because of that, and the construction of the X-ray tube, we're gonna have a difference between the cathode end and the anode end. So two things to remember about the heel effect. One is that the intensity difference is, the intensity is gonna be greater at the cathode end of the X-ray tube, lower at the anode end of the X-ray tube. And because of that, we put the thicker end under the cathode end of the X-ray tube, thinner end under the anode end. So you're shooting a foot, toes under the anode end, 4 foot under the cathode end. The other thing is you are going to see a difference in sharpness or recorded detail between the cathode end and the anode end. So what we have is a sharper image on the anode end and more penumbra, which is unsharpness, on the cathode end. Okay, so how you need to remember that, it's kind of up to you, but more and more is one way. So you're going to have more intensity on the cathode end of the X-ray tube, and you're also going to have more unsharpness on the cathode end of the X-ray tube. Okay. All right. So one thing that I put a star outside because I just completely, went right past that. That is spatial distortion. That's misrepresentation of the size of an object by virtue of its position in the body. And if you have your textbook, you can see that reflected on figure 21.11. And what that is the image is reflecting two arrows at different OIDs, essentially. The one at a greater OID is smaller than the one at the lower OID. Okay, but because of two things. One is it's out of the middle of the central ray, so we've got an angulation on the central ray, which gives us that parallax, right? And because of the increased magnification of the one that's further away from the image receptor, the one that's smaller and further away from the image receptor appears to be larger than the one that's closer. Okay, so spatial distortion is misrepresentation of two different objects, one that may be smaller than the other appearing larger than the one that's actually bigger. In spatial distortion.
Yeah. Would you like us to be able to work the focal spot blur formula for this stuff?
Focal spot blur formula, that's a good question. I don't know that there's a question on the test about focal spot blur, working focal spot blur. It's kind of a complicated formula, so I would lean towards there's not one.
Okay,
You know?
Just as stage 286 calculated in
Yeah. I think components is what I'm looking for on the test is, what do you need to know to calculate it, more so than actually calculating it.
For focal spot?
Focal spot blur.
Is that,
Putting formulas into a Word doc, I'm about as computer illiterate as you're gonna find, to be completely honest. And putting formulas into a Word document just never looks right to me. So that's why I put, the page number on there. All right, so let's see. What else? Distortion. Remember, we have two different types of distortion. Let's get up to that. Two types of distortion. We have two other types of distortion. Main types of distortion. We've got shape distortion and size distortion. Well, we'll start with size distortion. That's just magnification. Increase in OID. You can get magnification by just decreasing SID, but most of the time it's going to be increased in OID. All right. The other is shape distortion. We have two types of shape distortion, both of which can be referred to as unequal magnification. So if you have a question that says an image is misrepresented equally in its size, then what are we talking about there? Equally magnified all the way across the image.
size distortion.
That's just size distortion, that's magnification, right? So, shape distortion would say something about unequal magnification. So, in those cases, what you've got are three different things to consider. One would be the body position, right? And that usually is going to lead to foreshortening. Where we have body positions that appear to give us elongation would be like in the pelvis, right? In the pelvic wings are kind of sticking out like that, right? So as we oblique the patient up, then the pelvic wing on the side closest to the image receptor, if we're shooting AP, looks longer than what it did here, right? But is it truly longer?
No.
The answer is no. You're just seeing it more represented as its normal shape. So it's not really elongation. So most of the time when we got, it's because of lack of foreshortening that it looks longer. Does that kind of make sense? So a normal lay of the pelvis in an X-ray exam, we have foreshortening. So foreshortening has to do with the angulation of the anatomy. Elongation is usually going to have to do with angulation of the central ray or angulation of the image receptor. Okay, so either one of those two can give us elongation. Also, though, is what we looked at before, is, and it's really the same thing, is if we're in the periphery, we can see some elongation. But it's really the same thing. It's because of the divergence of the central ray, we've got an angulation by the time it gets out of here, right? So it's still angulation. So angulation of the central ray, angulation of the image receptor, both can give us elongation. Both of those are shape distortion. Both of those may be referred to as unequal magnification.
Elongation and what else? Sorry.
Shape distortion.
Yeah, well, shape distortion is elongation and shape distortion. And then what was the other one?
Oh, foreshortening.
Foreshortening.
Yeah, foreshortening. By the way, I don't know if it's on this test. I think it's in sophomore year because sometimes I get questions in sophomore year that are, I gotta admit they're gotchas because you really should know better by the time you're a sophomore student. There is no such word as for lengthening, okay? Just, I'm not gonna tell you that in the sophomore year. You just need to know there's those. I'm a wordsmith. I just make up words sometimes. Yeah.
But sometimes there are other words for things that you don't always tell us.
Sure. If I gave you alternate words for everything I say, I wouldn't get past.
Like, for example, last semester, I didn't know that voltage and potential was the same thing. Is it going to be like the same type of thing?
I think I covered both of those.
Well, in like the very beginning, it was
Yeah.
like that they were the same
Yeah.
thing.
Yeah.
Is it going to be like the same thing?
Yeah. All this time, I just gave you 4 different words for whatever it was.
The chart.
Huh?
There's a chart.
H and D curve, yeah.
Yes, but you told us that it's the same
Yeah,
thing.
yeah. Well, hang on to it. So, yeah, it could come at you any of those ways. I try to at least, hit on all the different words for it. Maybe not every time. Okay, so three geometric factors. We have magnification, distortion, focus, spot, blur. Are 3, geometric factors, and then we've got controlling things within those. So magnification, that's going to be your OID, your SID, and your really pretty much that's it. And for distortion, what we want to get a completely undistorted image is to have the anatomy and the image receptor to be parallel to each other and the central ray perpendicular to both of those, right? So even with that though, because of the divergent central ray, we might see some sort of misrepresentation. Shouldn't be bad. Magnification factor. scroll up. If y'all see something I need to stop on, let me know. Remember we have two different types of contrast. We have subject contrast and we have radiographic contrast. We have subject density and we have radiographic density. So let's start with density. Subject density just means the compactness of the tissue types. Air has no compactness to it at all, so it appears very dark. Soft tissue has a fairly similar atomic number as air, but it's very compact, so it shows up as a lighter thing. Bone, totally different atomic number and very compact, so it shows up very light. So density, radiographic versus patient density, there's going to be an inverse relationship, right? So the more dense the structure, the lighter the image. So as patient density goes up, radiographic density goes down.
Mm-hmm.
Anytime that we have contrast is going to be, going the same direction. So if you have high patient density or high patient contrast, you're going to have high radiographic contrast. Bone and air, high contrast. Bone and soft tissue, lower but still high contrast. Soft tissue and soft tissue, it's a gray mess. Right, you may be able to see, certain things, psoas muscles, kidneys, things like that, but very, very low contrast.
So is that because whenever your patient density, that goes off like your Zeph number and like how compact tissues are,
Right.
And then the radiographic is the darkening. So if you have like a high one, you're shooting a bone, it's gonna be really light,
Right,
which means a low radiographic.
right,
Okay.
exactly.
And then but contrast there, like one goes up, the other goes up.
So health, here's a good example. And I think I might have told y'all about this last semester, is that, you know what atrophy is, right?
Mm-hmm.
That's, you don't use it, you lose it.
Yeah.
And I was, this is when I was clinical instructor, I was out at UT North, and we're doing a PA and lateral chest x-ray. I was working with a student. We're doing a PA and lateral chest x-ray on a lady who was an above the elbow amputee, all right? So what are you gonna do with this stone? Yeah, well, for the lateral chest x-ray, that's what we wanted to do, but because, it had no use for her. Usually if, like, somebody needs an amputation, they'll try to save the elbow and a little bit of the forearm because, if you're writing and you're only writing with one hand, what happens to the paper? It moves, right, so they can use, it's a paperweight, essentially, okay? And it's bad, it sounds bad, but it's still useful. But here, you can't really do that. So disuse led to osteoporosis in that arm. That's disuse osteoporosis. She didn't have general osteoporosis, it was disuse osteoporosis because there's no weight bearing on that arm. You don't use it, you lose it, right? So in addition to that, because she didn't have a reason to use it, she lost range of motion. So I went all that way to say, we did a lateral chest x-ray, she couldn't get that arm up and out of the way. So we shot straight through with that arm down to her side, and you almost couldn't see it. You almost couldn't see the humerus because the osteoporosis was so severe. So contrast was very low for, that where that humerus should stand out, contrast was very low because she lost some of the Zeph number, some of the denseness. Okay,
Meaning
so
a bunch of shades of gray.
what's that?
Meaning a bunch of shades of gray.
Okay, okay, let's go into that. All right, so contrast, yes, in general. So contrast, all the words for contrast. So we've got high contrast, means very black and white, right? And we're going to get shades of gray in just a second. But high contrast means very black and white, right? So high contrast would be short scale because you go from white to black in a great big hurry, right? So short scale, high contrast, and that would also be referred to as low latitude. Okay, so all three of those mean the same thing. And maybe a fourth that I've added in here. I don't remember exactly. I was doing a lot of stuff yesterday. Alright, so then we get into shades of gray, and shades of gray are, kind of backwards from all that. So if we have, low contrast, that means we've got a lot of shades of gray. So we lost the humorous, so it became instead of a high contrast, it became a low contrast subject, density. So low contrast, long latitude, a lot of shades of gray, and what was the other one I said just a second ago? Long grayscale. Yeah, thank you.
Can you kind of put latitude and grayscale together?
Yeah, latitude and grayscale go in the same direction. They're inversely proportional to contrast. Yep, yep. All right, so all of that's controlled by those things that we were talking about before. Primarily tissue, the mass density and the effective atomic number, but thickness does play a part as well. If you have a structure that's got a lot of soft tissue, then you're gonna have a gray image. Think of things like, your knee versus a KUB. A knee and a knee, you've got three great big bones and one small bone, the patella. And you get an image that has very high contrast, but you shoot KUB and you've got kidneys, liver, spleen, intestine, fat, all the stuff. And it turns out very gray. Okay. So then if you have somebody who's asthenic, you don't have a whole lot of that soft tissue, and it's gonna be higher contrast than somebody who's hypersthenic. It's gonna be very gray. Okay? So the main things are going to be your tissue mass density, but thickness and effective atomic number, but thickness also plays a part. So we also talked about object shape, and all right, so in your sophomore year, again, we're gonna talk about a thing called modulation transfer function. You don't need to know that right now, but modulation transfer function is kind of the marrying of contrast with sharpness or recorded detail. And I mention that now because of this, all right? So you've got a round object, and we talked about a round object is always gonna show loss of sharpness or recorded detail because you can't put the fattest portion closest to the image receptor. So you're always gonna have an increase in magnification, and we're gonna have more penumbra, right? So thinking about penumbra, and you see how well the shadow looks here, and let me do this so that I can get closer to that. You see how well the shadow looks here, right? But if I get way out here, what do you see?
Blurry.
It's blurred. Okay, but can you say that the difference between the shadow of this thing and the shadow of, lack of shadow of anything else is high contrast?
Yeah.
Yeah, it's still high contrast. Does it look more high contrast here?
Yeah.
And the answer is yeah. Okay, that is what we refer to as absorption blur. Now, if I had two of these things and there was a gap in between them that was just like an eighth of an inch, and I kept them, as best I could, to where the light could go through that eighth of an inch, and I brought it way back here, would that fuzziness overlap maybe?
Mm-hmm.
Yeah. So you're going to have loss of sharpness or recorded detail and the appearance of loss of contrast, and that's your absorption blur. Okay? So absorption blur is going to be worse, again, on round objects because you just can't get it close to the image receptor. So in a digital world, modulation transfer function is kind of putting those two things together to try to get the best contrast out of those low contrast things that might have a little bit of absorption blur to them as well. So we'll get into that in the fall semester.
So on absorption blur, we just need to know that it's worse on round objects?
Yeah.
Okay.
Yep. Let me say this. Anything with an increased OID.
Yeah.
And the type of structure that you can't get away from absorption blur would be a round object. Just dial it in a little bit tighter. Okay, so here's all the stuff on contrast. Let's see, now the difference in, we kind of did that, so there may be a little bit more information on what we just talked about. So you may see a question that refers to, you know, the type of tissue that has the maybe the greatest to the least subject density, right? Or the least to the greatest, and from the least to the greatest, it would be air, fat, any kind of soft tissue, muscle, and then bone, right? From the most dense to the least dense, it'd be in the opposite direction. Or you may have a question that says, what gives us the most or least radiographic density? So least radiographic density would be bone. The most subject density would be bone. All right, so now we're going back to the difference between subject and radiographic density. So this tissue densities, least to most, would be air, soft tissue of all kinds, soft tissue specifically muscle, and then bone. Reciprocity, remember what that is. It's you know, manipulation of MA and time to maintain the same mass, and we use that in two different ways. One is to reduce motion artifact, and this whole thing should be red, I think. One is to reduce motion artifact, and that would be to increase MA, decrease time, right? And we also use it to take advantage of motion artifact, and that would be in things like breathing techniques, wagging jaw, Ottenell method. So all the information on H&D curve, which will stay here. Speed, remember, speed means sensitivity of the image receptor. The more sensitive it is, the less radiation it needs, and the numbers represent the speed. So the higher the number, the faster the image receptor. Faster the image receptor, the less radiation you're going to need. So what you might see on a test all the way through the registry is that one disadvantage of high-speed image receptors is that it could introduce quantum model, right? Because quantum model has to do with lack of mass. The higher the speed of the image receptor goes, the less mass you need could introduce quantum model. Okay, so you may see that somewhere. Also, you might see, if you're doing registry review books and, you know, like, I don't know, Red Tech Book Camp or something like that, you might see a residual question, possibly even in your DeAngelis, that refers to loss of sharpness reported detail in high-speed image receptors. That's not really a thing anymore because we only use one image receptor, right? You just use the one pad. So you're not really changing speeds anymore, so you know, I don't know that it really has a place anymore. So I don't think that's going to be on the registry, but you may still see it as a holdover from screens and films, and that would be that truly the faster the screens and films were, the more inherent unsharpness we would have. Okay, and I'm not going to get into why that is, but you may see that question.
So what do we need to know for this one? We need to know that quantum model is more likely with a higher speed IR because it's more sensitive.
Right,
Okay.
right, and you need less mass.
Yeah.
Yeah, yeah. You also need to know though that the speed is relative to the number, you know, so 400 speeds twice as fast as 200
Yeah.
speed,
Mhm.
those things.
Yeah.
Yeah. So quantum model, we've kind of done that to death. That's a speckly appearance. Could interfere with visibility. More contrast resolution. Okay, so two different types of resolution. You have spatial resolution, that's your actual sharpness. So what you're going to look for there is geometric factors, that's one thing. Sharpness or reported detail, just sharpness or just detail, okay? That's all talking about the sharpness of the shadow, okay? That's controlled primarily with those three things again: low OID, at least adequate SID. If you increase OID, increase SID, and also focal spot size. Small focal spot size gives you better sharpness or recorded detail. So that's all spatial resolution. Also, angulation, foreshortening, types of distortion. The contrast resolution, the questions on contrast resolution are, if it says resolution and it's talking about contrast, it's always gonna have that qualifier. With spatial resolution, it might not, but if you see resolution and it doesn't say contrast in front of it, you gotta be thinking spatial resolution, sharpness of reported detail. So contrast resolution is either gonna say contrast resolution or just contrast, okay? And that's difference. All contrast is difference. Difference between dark areas, light areas, difference between anatomical structures and whether or not you can, image and visualize those differences. Kidneys versus all the other mess that's in that abdomen. Psoas muscles as opposed to everything else, right? So contrast, spatial resolution. You want to scroll back down through this and see if there's anything else that you want me to touch on? Yeah.
So going back to the example of the lady with osteoporosis on her humors,
Mm-hmm.
that would be considered, what is it, high subject density?
Low,
Low?
yeah.
And low subject contrast.
Yeah, low subject contrast, both, yeah. Low subject density and because it looked more like the lungs, low subject contrast. And so what that gave us then is higher than what it should have been, radiographic density, and really, it would have been low for that anatomy for the humerus would be low radiographic contrast.
And low set number.
Yeah, yeah. Ish. Okay. All right. I make that distinction because Zeph number is really the effective atomic number. It's still bone. It's just that it's not a whole lot of it there, right? So it's not so much the Zeph as it is the quantity of the bone there. Does that kind of make sense? Sort of.
Same as like
Yeah.
area tissue, that kind of
Yeah,
idea.
yeah, kind of. It's like
I mean, could you?
I don't know. I don't have anything.
Could you
Just
use it like if you're X-raying like a water ball full of something, and you just take out more and you see less of them? I mean, could that?
if you take out more of the water, you see.
No, so like, say you have like a bottle full of like lead beads, and you have like 100 of them. You
Mhm.
shoot it, and then you take out
Oh yeah,
90 of them and spread them out.
yeah.
You're gonna see through it better.
Right.
Yeah.
Exactly. Does that kind of make sense?
Yeah.
Yeah. So it's still lead beads. It's just that you don't have as many, so they don't show up as well.
Yeah.
Very good. Very good. Thank you. I was afraid I was going to throw something out there that was just going to confuse you. And I do that. This is your second semester. I can do that. All right. Well, somebody tried to post something that looked like I had an anonymous, but there was no question. So, that'll remain open all weekend. Probably I'm not going to look at it over the weekend, but I'll address any questions you have on Monday.